Good afternoon, everybody. My name is Dr. Dennis Dietzen. I am affiliated with the Department of Pathology, Immunology, and Pediatrics at Washington University School of Medicine in St. Louis, where I am the Medical Director of Laboratory Services at St. Louis Children's Hospital. And this afternoon, I've been asked to talk to you about the importance of laboratory developed tests, or LDTs. What are LDTs? So on the laboratories have a variety of tests that we perform of varying complexity. The simplest test that we perform, you might know as things like point of care glucose meters and things that require very little technical skill to perform and get an accurate result. So it's kind of like going through the drive-through at McDonald's at the lower right and just picking up your dinner with very little preparation. Then there are tests that we refer to as moderate complexity tests. And the analogy I like to use for that is the hamburger helper analogy, which is in the middle on your right. You know, most of the basic ingredients are there, but they might require a little bit of additions to make the meal, to make the test work. LDTs are the highest complexity test that we do. And that's the analogy for that is cooking from scratch, cutting up the vegetables, prepping the meat and everything, and all of the seasoning that goes into that. So scratch cooking is an LDT. But LDTs, there are varying flavors of LDTs as well. So an LDT can be as simple as an FDA approved test that we have to modify in some way to make it work in our environment. So we're no longer using it according to FDA guidelines, but we're still using the basic tools. So things like a change in sample collection, or a change in sample type, or a change in patient population, or a new interference that we detect. So if we make changes to that method, that now becomes an LDT and we become responsible for its performance characteristics. But then there's the really complicated ones, are the cooking from scratch ones, where we have to formulate buffers. We may have to formulate PCR primers. We may have to make our own calibrators. We may have to buy our own enzymes. And to do that, we have to worry about the type of instrumentation we have, and we have to worry about our own supply chains, which will become very important later in the presentation. But then after we build it, we have to figure out if it works. So, and that's one of the harder parts. You know, we have to determine how precise is the test, how accurate is the test, what is the range of values that we can confidently report. What does this test look like in a normal population? How do we handle the sample to make sure that the results that we get from that sample are accurate? So we have to do all that. We already have to document that. And when inspectors show up and when CAP inspectors or CLIA inspectors show up in our laboratories, we have to produce that documentation to show that we've done our due diligence to figure out how to make sure that we've done that test properly. So why do we do LDTs? We do, in a pediatric environment, we do a fair number of these, and a lot of times in pediatrics, they're unmet needs. We deal, one of the biggest sets of LDTs we have in my laboratory are used for inborn errors of metabolism, which are, individually quite rare, but collectively not so rare. And there is no profit motive for a company to build FDA approved tests in that environment. So we have to build those ourselves, or the patients go without care. Sometimes LDTs are prompted by new knowledge of pathophysiology, new biomarkers that appear to give us clinical information that we couldn't heretofore get. So they're often done, they're not usually done in a vacuum by the laboratory. They are often done in collaboration with our physician colleagues. They know what they need to know. And we know the analytic limitations and the interpretive limitations that will come with the testing platform that we are developing. So we always talk to our clinician partners when we do this. They may be used for diagnosis. They may be used for prognosis. And they may be used to decide if precision therapeutic tools are indicated. So there's a broad range of clinical indications for using LDTs. They are seldom used by themselves. Decisions are not made simply based on one LDT. They're one of multiple diagnostic tools and one of multiple clinical tools that physicians lean on to make diagnoses in their patients. So in many cases, the entire diagnosis and treatment protocol is not writing on a single LDT. So who develops LDTs? I do, but why can I do it? They're typically developed by incredibly highly qualified, trained physicians or PhD scientists. They're limited to laboratories that have the permission to perform what we call high complexity tests. That is only about 4% of the entire lab universe in the United States at this point that are eligible to perform these things. It is not something we like to do. It is often something that we have to do because it is a significant monetary and time investment. The people who build these tests, they all have bachelor's degrees. They either have MDs or PhDs. They will typically go through a residency program if you're an MD pathologist. As a PhD scientist, I went through a laboratory medicine fellowship to learn how to do this. We have to get the experience necessary and pass an exam for board certification. In my case, I am a diplomat of the American Board of Clinical Chemistry. And then we have to demonstrate to that board on an ongoing basis that we still know what the heck we're doing. And that's called maintenance of certification. So PhD scientists and MD scientists both have to do this. So it's not for the faint of heart. It's not for the untrained folks to do this. There's an incredible amount of education and practice and that goes into being able to build these tests the right way. So why do we develop tests? I alluded to this earlier. Why do we develop LDTs? One reason is there aren't any tests. Inborn errors of metabolism like phenylketonuria, I'm sure you've heard of. MCAD deficiency is a disorder of children where they can't burn fat. So if they get hypoglycemic, if they get sick and they can't eat, that can be a catastrophic disease for those kids. Cystic fibrosis is a rare disorder that we build laboratory developed tests to diagnose. The sweat test that is the gold standard for diagnosing cystic fibrosis is often a laboratory developed test. We also develop LDTs if we have a currently FDA approved test that doesn't do the job we need it to do. A great example of this in my laboratory are drug screening immunoassays. Immunoassays for drug screening suffer from low sensitivity. That means they can't pick up a lot of drug, and they often lack specificity, which means those detection systems can detect drugs that are not really there. And it's particularly important in little babies when custody decisions are being made and treatment decisions are being made in children. And there are some situations where, the clinical environment, the clinical landscape has shifted in such a rapid way that we need a test to fill a void in a hurry. And we don't have time for a diagnostic manufacturer to make the test, validate the test, and run it through the FDA to get it approved. An example that I will talk about in a little bit is COVID. Another example that happened in our area very recently is we had a supply of synthetic cannabinoids that was laced with brotafoquum, which is an anticoagulant, and folks were taking these synthetic cannabinoids and bleeding, and in some cases the outcomes were poor. We were able to develop a test very quickly to identify those substances, and when patients presented, we knew what was going on with them. So sometimes it's just we need extra speed to be able to do this. How are these LDTs important to patients? Like, as again, I keep banging on the rare complex disorders. In pediatrics, there are a lot of kids that have very rare, very complex disorders that take a while to figure it out. So we have to be able to diagnose and monitor those kids in real time. There is either no test available. When we can't test and make a diagnosis, that failure to diagnose can lead to suffering. What it also does is it leads to unnecessary costly testing and usually inappropriate care. And I've kind of diagrammed that outline here. So if you start on the left side of the screen where it says rare complex disorders, there's two pathways you can go down. You can go down the pathway of a definitive LDT to make a definitive diagnosis. Then you can provide specific treatment, and you can often use that same LDT to monitor how they are doing. And that outcome is very good because it can happen in a relatively short period of time. And particularly in kids, if you delay a diagnosis and you delay treatment, the longer that disease is allowed to progress, the worse off those children are going to be developmentally. So the lower part of the graph is what happens if you don't have LDTs in some of these situations. You might run a series of tests that might give you a few clues as to what's going on, and you'll get some information. You might try a few different compounds, a few different therapeutic modalities. And what usually happens if you're wrong is that you get into this loop where you keep doing testing and you keep trialing therapies and patients don't get much better. So there are complications from this that might last a lifetime, and the clinical deterioration does not stop. So you get into this endless loop. So in many ways, the purpose of these LDTs is to stop that endless loop of testing and get patients the diagnosis and the care that they need in a short period of time. So I want to spend a little bit of time just talking about the landscape of COVID testing that rolled out last spring. There initially down at the bottom, I've kind of diagrammed this. When COVID showed up, it did surprise most people. The CDC had some tests available. The WHO had some tests available. In Missouri, where I practice, with the public health laboratory in the state of Missouri rolled out the CDC test. And as we know, in retrospect now, we know that the CDC reagents were contaminated. So there were a number of problems, false positives, false negatives with those tests. In addition, those public health laboratories didn't have a lot of those reagents available. The turnaround time for those particular tests in our situation was a week to 10 days. So if you're trying to prevent asymptomatic transmission of the virus, you're trying to identify people to isolate, and you're trying to identify people who they may have come in contact with to reduce the spread, that is not quick enough. So the laboratory community, in what I consider to be one of the more impressive efforts that I've ever witnessed, started to work on LDTs to try to detect COVID-19. So what we did is we assessed our supply lines. We assessed our reagent supplies. We did have to assess the regulatory environment as we were doing this. And what we ended up with in our institution is we ended up, because of the volume that we had to test for, we ended up with multiple LDTs on different platforms with different reagents and different supply lines with multiple samples, from NP swabs to nasal swabs to saliva samples, and multiple supply lines that we had to depend on, because from day to day, we didn't know what supplies we were going to be able to get. And so, as we progressed and as we improved these tests, we were quite ready to go, but then there was the FDA EUA protocol that slowed us down and hindered us to getting this test into circulation. It was ready to go, but that extra regulatory hurdle delayed the implementation of these tests. And eventually, within the course of 6 or 8 weeks, we ramped up the number of these that we could do in real time, but the supply was still inadequate at that time until the bigger commercial manufacturers got on board and managed to make high throughput reagents for some of their commercial platforms. So these are the lessons learned, I think, from that, is that, LDTs certainly meet immediate public health needs, and they meet the immediate health needs of a lot of different patient populations. Regulations, even well-intentioned and not, if they're not well thought out, might be a barrier to patient care. The rapid deployment of LDTs was critical to that first wave and flattening the curve from that first wave. For all of these LDTs, the last statement is applicable. Additional regulatory burdens, like I say, we build these tests in a very highly controlled environment with people that are well trained to do these things, and additional regulatory burdens and costs will hinder their development. And LDTs are the place where laboratorians innovate. This is where, the LDT of today is the FDA approved test to tomorrow. So additional regulatory hurdles may push some laboratories that might do an LDT, they might push them out of that environment. And, in the process, that the patient population that they serve will likely suffer. from that. So that is a quick sort of survey of the landscape of LDTs and how we use them, how we build them, and why we think they're critically important to taking care of patients for a lot of different reasons, whether it's inborn errors of metabolism or infectious diseases. I thank you for your attention again, and I hope that the last 10 minutes or so has been enlightening, and via our associations, I'm happy to answer any questions that you might have about the subject. Thank you very much.